I use my Amazon Echo to tell me a bed night story every night. So I go Amazon story time, and it tells me these like little great stories. But my husband says I fall asleep before the story even is over, and so I really don't need any help sleeping. But me and Amazon and that Echo, it's all over the house, and I tell her to turn on the lights, turn off the lights, and my sister looks at me when she comes to visit and goes, "The switch is right there." I'm like, "Yeah, but it's more fun that way, right?" It's part of my health IT, I think. So once again, I'm Karen Kennedy, and thank you for joining us. And as a clinician, I can't stress how much enough, even in my health IT world, that it's all about the patient. No matter what I do every day when I'm working and volunteering or getting paid, it's really about the people that you're seeing on the stage right now. And like I said, I'm passionate about helping my clinicians. I'm passionate about helping my patients, because ultimately, whether you're in IT or anywhere else, it's the voices of the people that we provide care to. And any one of us sitting in this chair at this given moment can be a patient. When I was a trauma nurse, and I went to work in medical surgical unit, and I worked at Robert Wood in New Jersey, I had a 16-year-old patient who had just gotten his license, and he was supposed to only, drive with someone, but he somehow got on a motorcycle, and he got into a severe accident, and he was in a coma, and then he became a little bit better, but he never really spoke. And all I could see was this scarred face that I was taking care of. So I asked the parents, can you bring in some pictures of him so that I can actually see what he looked like? And he had hair, he had a girlfriend, he had cool clothes. All I ever saw of him was that hospital gown and a shaved head and scars on his face. And so it helped myself and my other clinicians and nurses actually see the patient for who they were. And so I want us all to remember that it's not about anything else that we do, but it's about that person that's lying in the bed that is a true individual that we're caring for, whether we're in IT or directly providing care. So I want to thank my panelists for coming today and volunteering to share their experience. I will ask each of them first off to go through and introduce themselves and give us a positive experience that you've had with regards to your patient care. And I'll start with you, Mary.
Good morning. I'm Susan Fischer. I am the Director of Home Health Operations for Scripps Home Health, or for Scripps Health. I'm a registered nurse. I've been a registered nurse for 28 years. And my positive story is that I'm not a good patient. I'll be perfectly honest and say that. So I think most nurses will agree that we are not good patients and we have expectations. But I had a great story a couple of years ago for myself where I had what started out as a small little scratch on my leg that turned into something unbeknownst to me that I never thought would happen to me, because I'm a relatively healthy individual, and ended up having to go to one of our clinics almost every other day because they were trying to figure out what was wrong with me. And as it turned out, very simply, I was allergic to the adhesive on the bandages I was using. So I went from a tiny little scratch to a wound that was probably about that big, and couldn't figure it out, and it was the bandage. And finally it was one of the nurse practitioners who identified that was the problem. So that was my great experience.
Good morning, I'm Diane O'Gorman. I'm not here as a patient this morning. I'm here as a caregiver, and I am a registered nurse as well, so I've seen it from the family side and from the nursing side with some experiences in my family. I'm a clinical informatics nurse now, but I spent 30 years at the bedside as an ICU nurse and an ED nurse, and I got a very intimate look at the caregiver side or the family side of both of those areas. It was very eye-opening. The positive experience there was the care that was given to my husband was extended to me and my family as well. Our children and I were humbled every day when the nursing staff and the physician staff and the housekeeping staff asked us what they could do for us that day, because we weren't the patients, but they were caring for us. And it made me it made me hope that I had offered the same type of care for my patients throughout the years that I was at the bedside. Sometimes it made me think about going back to the bedside to offer that type of care, but I like the informatics side, so I'm not going back to the bedside. I don't want to do the weekends and holidays anymore.
Thank you, Diane.
Hey, good morning. My name is Tony O'Gorman, and this is my wife, Diane. And if you watch closely, you'll see her blushing in a few minutes. 2 years ago, I was riding my bike out in Ramona, and I was riding down the hill too fast, and I hit a rock wall at 45 miles an hour, and I broke 22 ribs, separated both shoulders, shattered my shoulder blade, and I punctured a lung, and I was airlifted to Palomar, and I was there for a month. And while I was there, shortly after I got there, Diane made an 8.5 by 11 piece of paper to put up on the wall. It said, "Remember rule number 5." And most people don't know this, but there's kind of a light-hearted list of biking rules. There's 95 of them, but rule number 5 is harden the fudge up. She's blushing right about now. And it just said, remember rule number 5, but it didn't say what it was. And in Palomar, everybody who came into the room asked, well, what's rule number 5? Even the people who came in to turn me, what's rule number 5? And the interaction with the staff at Palomar was excellent. When you're in the hospital, or at least for me, I kind of felt like, okay, they're just seeing a black and white picture of me because they just see, okay, here's his, your birth date, here's what happened, blah, blah, blah. But as people begin to ask you what you do, how are your kids doing, your wife, and they begin to find out more about you, you kind of feel like there's color coming to the story and there's color coming to the picture, so they see you as a person. I was at home for a month, and the fluid that had built up outside the lining of my lungs became infected. So I came back into Scripps La Jolla for a month, had a big empyema, and while I was there, people also asked a similar question, what's rule number 5? And they interacted with me a lot. But after the first hospital stay, I was in Scripps Encinitas for a week for rehab, in-hospital rehab, and nobody there asked what that rule number 5 was. And it made a big difference because I also saw that I found it very, very hard to interact with the staff and interact with the people. They just come in, okay, here's your meds, and they're gone. And you kind of feel radioactive, as if there's a timing limit on how long they can spend in the room. And I just couldn't wait to get out of there. So for me, I think it's very boring just lying there all the time, and having somebody to talk to and interact with, joke with, that made a big difference. And I guess that summarizes kind of my experience.
Thanks, Tony.
Hi, I'm Dave Sheehan. I actually cycle with Tony. That's how we know each other. So he does follow rule number 5. I'll let you know right away. So I'm also, I guess, been fortunate to be a patient, I guess is the way I'd put it. I had 2 hemangioblastomas, 2 craniotomies. The first one was not successful. I'm a father, I'm a husband, and I'm used to being in control. I also run a company. And so going through that process is incredibly humbling. It's enlightening, but there's a fair amount of where you lose control. And the things that go well for me are the simple things, the little things. And I remember I was on meds dealing with pain, and they couldn't get control over it. And a nurse came in and just held my hand. And to me, it made me feel better. It's those simple gestures. I think going through the healthcare system is a loss of control. And it doesn't matter who you are. Most people are used to doing things they want to do every day. And when you go into the healthcare system, you're not controlling it anymore. So you're at the control of the people around you. And if your judgment is clouded because you're on meds or you've had anesthesia, it's hard to you have to have confidence in everyone around you. And so for me, it's those little things that matter, because you want to feel like you're in control and you're really not. I've been fortunate. I had the first surgery was unsuccessful, but the second surgery was successful, and I'm 11 years out and living my life.
Thank you. And so those are some positive experiences. And this panel is really here for you guys. I really want to keep this open, so if you have questions that you want to ask the panelists as well, feel free to raise your hands. Use the microphone if you have a smaller voice so that we can hear you, because I want you guys to be engaged in this discussion, because it's important that you hear not just from the patient, but you get information on how to engage them as well. So thank you for those positive notes. And as we know, in any situation that we're in, there are times when, we do things that need improvement, right? So I'm sure there are stories amongst our panelists of working in healthcare and being patients that have some opportunities for improvement. So I tried to keep a positive swing on that opportunity for improvement, right? So Susan, why don't you start us out and tell us an area where you saw some opportunity for improvement as a patient and or a clinician?
I think I'm going to turn this sort of like Diane, because one of the reasons that I'm here is also to talk about the caregiver perspective, so a provider of care to patients. And it can be very difficult in the home health environment because we're going into patients' homes. And there are tremendous expectations when we go into those patient homes. It's not the same as being in the hospital, where a clinician, a practitioner, a nurse, a physical therapist, a doctor is there throughout the day. This is a one-time shot each time you make that visit. And the least little thing can go awry because it's expectations not being met and or perceptions of how you're presenting yourself. And this is something that we in home health struggle with all the time. How do we identify what the patient is looking for? How do we find out what their expectations are? And how do we meet those expectations with every visit? It's also, we have changing hands with home health in that the nurse might be seeing you today, but the physical therapist is seeing you tomorrow. So there might be 3 or 4 different people that come through the door, and is everyone doing the same thing and saying the same thing? And how is it being perceived by the patient? So there's not a day that doesn't go by that we don't talk about this, because we're always focused on how can we improve our patient experience. This is one of our measurements that we give to our staff. This is one of the things that we monitor on a daily and on a monthly basis. So it is a struggle for us, but it's something that we're constantly looking for. So I just want to pass that little piece on as well, because it is a struggle to meet sometimes those expectations that patients have.
Thank you, Susan. Yeah, communication is always an area, and for us in health IT, is that communication, connecting the dots and the link, not just to the patient and the caregiver, but amongst various caregivers as well.
Right.
Thank you. Diane? She's like, I got a lot.
Yeah, there was so much that summer. There's so much to say. I think going towards understanding what the family and knowing the family, and I'm not saying anything against home care at all, nothing at all.
You can.
But
I'm
Well-
totally open to it.
well, when Tony, after his second hospitalization, move it up. Louder? Okay, so when Tony was in the hospital the second time and he was getting ready to go home, the caseworker came in maybe 2 or 3 days before he was supposed to go home and said, the home health care nurse will be coming in, and the physical therapist will be coming in, and we're going to arrange for your medications that you need to be delivered to your home. And I said, wait a minute, what do you mean? Nobody had come in and asked us about this. They said, well, you're a trauma, and we do this for all trauma patients. And we were both, time out, no. He's had this wound for this many weeks. We are not having somebody different come in and look at this wound and make a determination whether it's infected or whether it looks good or whatever. We're coming back here as often as you need us. You need antibiotics every day through the IV that you still have in. But the doctor who's been following you for a month in the hospital, he's not in the area that you live in up there, so you're going to have to go to another doctor. No. Complications from antibiotics, we're not going to a different doctor. So we refused the home health. Oh, and physical therapy. The physical therapist in the hospital told us there was nothing that they could do for him at home, that any physical therapy that he got would have to be done in a clinic-type setting or hospital-type setting. So they didn't come back in and ask us about any of that. So all of their plans were out the window. He had also been in the hospital for a month. I drove him every day to La Jolla, 25 miles a day, and neither one of us minded a bit. He got out of the house, and that's all that he wanted. And he went to physical therapy, and he saw the people. He also had a wound vac that our earlier doctor had talked about. They took care of that, and we were assured that the same people took care of us throughout the whole thing. And like I said, nothing with home health. We didn't see them, but we'd had a very bad experience after going home the first time without having follow-up care. So I guess that was my, people make assumptions and they don't come in and talk to you and find out what you want.
Thank you, Diane. I know it's you. You both are like a little dynamic duo when it comes to healthcare, and you don't realize how much you know and how much you can handle until you're in it together. So thank you for sharing, and I'm sure you're going to give us a take on your view, Tony, as a patient, for an opportunity for improvement as well.
I probably said everything maybe so far about, getting to know the patient. One of the things I like to do as well was to just get to know the staff. Did they have kids? Did they have a dog? What were their issues? Because I like to just engage with people and kind of find out, what were they all about? It just wasn't all about me in the hospital either. I was, very fortunate to have a wife as a nurse. So, when you're as drugged up as I was, things go in one ear and out the other completely. And I'm normally somebody who can pick up on those details and follow what's going on, but in the hospital I just wasn't able to. It just wasn't possible. I would say if you're giving care to a patient, no matter what the issue is, try and explain it in some sort of a common way. Use some analogy. That helped me a lot to understand, what had happened, and how I was going to get through it. And just echoing what Dave said about the loss of control, just understanding that you're not the only one who has lost control in the past. One of the nurses mentioned to me that she had broken some glass bottles and they got embedded in her hands. and she didn't have the use of her hands for about 6 weeks. So just her telling me that fact, helped a lot to put in perspective, hey, I'm not the only one who's gone through this. I guess one of the advantages that medical people have over other people is they're used to dealing with sick people and seeing sick people. But the normal person is not used to seeing that, so we don't have any perspective whatsoever on the loss of control, the issues you go through, the uncertainty, all of that. I guess that was a big part for me, just learning that I wasn't the only one who had gone through this.
Thank you, Tony.
Opportunities for improvement. I'll probably relate 2 stories. One was after my first surgery, I was told that both tumors were resected, and then 2 days later told that the second tumor was not at all. Started me on a path where I had to go back through finding another neurosurgeon. It was painful to say the least, total miscommunication. And to add insult to injury, I tried to find another surgeon to do it. It was in a bad place. And the surgeon that had passed on it the first time called that surgeon that I was reaching out to try and do the second surgery and told him not to do it. So hard to believe that went on, but it's reality. I did find a guy that did it, and he was an amazing guy, and I had a successful outcome. It was a 12-hour surgery. When I got out of it, I was, without a doubt, on hard edge. You wake up. If you want to lose control, go sit on an operating room table naked. There is no other greater loss of control. You are put out naked on an operating table. And afterwards, just going through that process, you have to give the patient control. You have to make them the center. They're already vulnerable, and understanding that and making it their journey, helping them through that journey is part of what, and you need to know who they are. Where did they come from? Some people are okay with that. I wasn't. I'm the CEO of a company. I'm used to calling the shots. I'm used to being in control. I want to know everything that's going on around me. You can't do that in that situation as much as you want to. And one, you're not mentally right. But I think having caregivers that know that spend the time to understand that, especially for acute patients, will go a long way. You make it a patient-centered journey, you're going to probably get a better outcome.
Thank you, Dave. I love hearing your story because you're very visual. When you say the words that you say, we can picture the stress, the sadness, the scary moments. Tell me about your loved one's journey around you as you were going through this experience.
One of the most difficult, things for me about the whole incident with the bicycle was it was pretty much self-induced. I didn't, a tumor didn't grow somewhere, so I felt very guilty putting my loved ones through this whole thing. For me, it was really exciting to pretend that I was 16 again for a while and flying down a hill and thinking that nothing could happen. But I had absolutely no idea whatsoever what the consequences would be and how much I would need the family and how much of an impact it would have on them. And that was extremely difficult for me, like I say, because it was, self-induced. I'm also fighting cancer, and there are some side effects from that which are very unpleasant. But I guess I look at that as just a tough luck story. Whereas the bicycle one, I really could have avoided it by just, not pretending to be 16 and not being maybe so reckless, but I just had no idea. And I think, the nursing staff in Palomar and in La Jolla did a very good job of including the family in the whole process. Number one, because my wife is a nurse, but number two, because it is so important to have the support of the people around you to get through this. When I was in La Jolla, when I was in the OR 7 times, and after the first time, Dr. Brewster, came in and said, hey, this is really bad. We haven't kind of gotten the full extent of it yet. We don't know what the impact of the infection is. And I went to bed that night, and I thought, okay, well, am I going to wake up in the morning or not? And my conclusion at the end was, well, if I do, I do, and if I don't, I don't. There's really nothing I can do about it at that point. And just thinking about the family, made that whole thing very difficult. But I'm extremely fortunate to have a family who was completely behind me, and my wife especially was in the hospital every day in La Jolla, and it made a huge difference to have kind of a focal point to aim at and just drive toward that point. I'm a little bit like Dave in the sense of, I'm driven as well. I like to have goals and get better and faster and all of that. But like Dave mentioned, the lack of control is significant. And you really have to reorient yourself as to what normal means and just to get kind of back on your feet. And having something to aim at was really significant. It helped me a lot.
Thank you, Tony.
I think that's maybe the hardest part is what's going to happen with your family. A stressful event brings out the best in people or the worst in people, and I think I'm a pretty relentlessly positive person, and going through that, I think one thing that helped me prepare for the surgeries were visualization tapes. And so I was mentally very ready going in, but I don't think it could have prepared me for what it was like coming out. And, I think my family probably fed off that on the upfront part of it, even though, there was a risk. I wasn't going to come out of surgery. They were very strong afterwards, and they were the anchor that I needed. My wife was extremely strong, and she gave me strength. And so I think you feed off each other. As Tony said, at a certain point, you can't control it. You don't know what's going to happen. You just need to let go. And I think that's the hardest part, is just the letting go, because you don't know if you're going to wake up the next day, given how you feel.
And the reason I ask these is, as a pediatric nurse, when I started my career, I learned very early on, you're not just treating the person in the bed, you're treating the person around the bed as well. So as we think about what we're doing in health IT, I want us all to kind of keep that in mind. Diane, I know you very well. I know because I've worked side by side with Diane and seen her struggles. And it's so hard to be the loved one and a clinician at the same time. Can you tell me a little bit about your mindset as you're trying to be clinically aware and astute, because you know that the person who is ill is really hearing like a Snoopy cartoon talking to them as a doctor is telling them information. They're really hearing you have and mom, and your treatment will be mom. And so then you're going to go home with mom, and then you will come back and visit us, mom. And so that is pretty much, and at the same time, so you're hearing that and trying to help decipher, take your notes mentally and physically, but at the same time you're being a wife. and you just want to hold hands and go through the journey together. So tell me about your experience on being both the RN and the receiver of care.
I think that one thing when you're a nurse, especially when you work in areas like the emergency room and in the ICU, when you're very involved with families and you've got a patient and their family comes in and they say, I'm a nurse, I'm a doctor, I'm a pharmacist, and as a nurse you go, oh God, what are they going to do now? And I didn't want to be that person. I didn't want to be the one telling the staff what to do or how to do it, or, you know, I just wanted to be that family member. I used to have families who would volunteer to help turn a patient because I couldn't find somebody or we had to wait 5 minutes. And they'd say, well, I'll help you, or I'll help you get them out of bed. And I was told that family, I said, no. I said, I've got workman's comp. When I hurt my back, the company's going to pay for it. If you hurt your back, you're going to sue us. You know, it's too much paperwork. So, so I tried to sit back and let others take care of Tony. But there were things as a clinician that I noticed with his bad lung injuries. After he hit this wall and he had all this injury, he actually never went to surgery in the first hospitalization. He had a chest tube in to reinflate his lung. And then he got a couple more in to drain some blood from around it, but he never had any surgeries after the initial injury. But I had worked, I'd been out of ICU for 20 years, but I knew of something called acute respiratory distress syndrome, where it makes it very difficult to inflate your lungs. And after 20 years, I still remembered that, and I remembered taking care of patients, and I remembered how sick they were, and what a critical condition that was. And so the second day that he was in the hospital, I asked about that. And I said, how about ARDS? And the nurse poo-pooed it. And she said, oh, no, Diane. You're thinking way long ago. You were an ICU nurse 20 years ago. She said, technology has advanced so much. Our vents are so much better. We don't see that very often. That was on Sunday. On Thursday, the doctor came to me. The trauma surgeon came after Tony had had a very bad day on Wednesday. The trauma surgeon said, we really underestimated the damage to his lungs. Severely underestimated that. And it's taking more pressures. And I knew he had ARDS. But I stayed off the internet because it had been 20 years, but I didn't want to read about it again. And our son was there at the time, and I was talking to him about it. Well, he didn't stay off the internet. He didn't tell me right then. I think it was a few days later when Tony was doing better and he was weaning off the ventilator. But Patrick said, yeah, these are the numbers, Mom, and when you're in this category, it's severe, and this is your mortality rate. And I'm like, thank you for not telling me that last week, honey. I really appreciate that. So it was really hard to try and separate. But yet when he went to La Jolla, and he was just mostly on a med-surg unit, he spent a little time in the ICU, but not nearly as much. He wanted to walk, and he wanted to be outside. It was July. And so they said, okay, you have to have a certified nursing assistant, a CNA with you to walk outside. Well, they've got 9, 10 patients. They're not like the nurses with just a few. They've got 9, 10, 12 patients. So we had to wait until they had time, and then we would walk outside, and he had a wound vac. He had an IV pole with antibiotics, and he had a chest tube, which it has a big container for fluid like this big. And they've all got their risks, and so we might get out once a day. And I said to him one day, I said, why can't I take him outside? I said, I'm a nurse. I said, I'm better qualified than they are. So at this point, I was taking off kind of that wife hat and putting my nurse hat back on and saying, let me take him. And they did allow me to. And by the time he left La Jolla, we were going outside 3 times a day. And I was using my watch and measuring it. And from his door outside, the 2 walks around the area that we went and back up to his room was a mile. So by the time he left, we were walking 3 miles a day. And that was for his sake and for my sake, because when he was in rehab, he was supposed to get out on a Tuesday, and this was maybe Wednesday, and my sister was coming that weekend, and it was my birthday on Saturday, and he said, I'm going home on Saturday. And he had only been there for 4 days. I'm like, no, you're not. And he's like, yeah, they said I have to be able to do this. He went home on Saturday. And that's pretty much how the rest of his stay was. I did talk the doctor, well, I didn't talk the doctor out of it. The doctor kind of realized when he wanted to do the same thing when he was in the second time from La Jolla, he wanted to go home a little bit early, and we kind of delayed that. But it is very difficult to remove the two things, but you also need that advocacy. And I don't know how anybody who doesn't have somebody in the healthcare field in their family can be a patient. I really don't, because you need that healthcare advocacy. It's amazingly complex.
I agree. Thank you. Susan, please share as well.
Well, I have two situations. One is for my husband, who, trying to calculate, I've been sitting here trying to calculate, is 7 years cancer-free following a prostatectomy, so prostate cancer. And we actually had the robotic surgery over at Mercy San Diego. And that's because I was an oncology nurse when I was at the bedside. And I saw patients, and I saw what would happen. And when he was diagnosed and said that it was more advanced than what was anticipated, they wanted to do all of the things that I remember seeing when I was at the bedside. And I was like, no, we're going to do this. This is the only option that I'm going to agree to. And I took it from that stance, and as Diane said, I think sometimes when you are in the healthcare field, you know more, and that can be just as bad as not knowing anything at all. So you try to stay as the caregiver, you try to stay as the loved one, and not be the nurse or the doctor or whatever role you play, and you struggle with that because there's an expectation sometimes. And I know for myself, I had to make the demands because my husband would have gone along with whatever they told him, because the communication isn't understood by most consumers. The other is something that is happening right now, and it's distressing for me because I don't have the ability to be with these family members, and because they're in Northern California. But it's my sister-in-law, and she had a pulmonary emboli, ended up going into cardiac arrest while she was on vacation in Idaho, spent almost a month in an Idaho Twin Falls Medical Center, was then airlifted to John Muir up in Northern California, and because she still wasn't stable, she is now in a skilled nursing facility. And my brother-in-law, who is a wonderful man but has no knowledge, he works for the IRS. I mean, that's his wheel well, right? And he calls me almost every other day. What am I supposed to do now, Susan? How am I supposed to take care of this? What am I supposed to do? What should I ask them? What should I, because the information, it's the want, but he doesn't understand it. And there's nobody else there, and I can't just pack up and go up there. And I said to my husband after I got off the phone with him last night, I said, I really feel like I have to say to him, let's transfer her down here so that we can care for her together, because I can't go up there and do what you need as a caregiver. I can only give you information and hope that you follow up with it. But I know just from his repeated questions that that's not always the case. He's still hearing the want, and not knowing what to do with it. So.
Thank you. I want to open it up also so that you guys have an opportunity to also ask our panelists any questions as well. So if you have any questions, let me know.